Hello, 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 everybody. Welcome, welcome, welcome. Today, I'm not used to saying today, it's usually tonight. Today, our guest is Dr. Rachel A. Davis, Associate Professor, liver donor, and author of Lithium and the Living Kidney Donor, Science or Stigma. Dr. Davis is an Associate Professor of Psychiatry with a secondary appointment in neurosurgery at the University of Colorado Anschutz School of Medicine. Rachel is also a non-directed liver donor, donating the right lobe of her liver in January of 2022. This experience has fueled a desire to increase awareness and advocacy about living liver and kidney donation. She has written a research paper entitled Lithium and the Living Kidney Donor, Science or Stigma. Her experience with donor denial and the use of therapeutic lithium in the treatment of mental illness is telling and interesting, and that's what we're going to talk about today. Please give a warm welcome to Dr. Rachel A. Davis. Doc, how you doing today?
I'm great. Thanks so much for having me.
Very glad that you're here. Please tell me, did I make any mistakes in the introduction?
Nope, sounded good to me.
Great, great. You got a friend already that's saying hello, but they don't tell me who they are. So, hello, Dr. Davis.
Hi.
Please tell us a little bit about where you grew up, your education, and your employment experiences.
Sure. So I grew up in a little tiny town in rural southeastern Colorado, Eads, Colorado, about 800 people. I moved to Boulder, Colorado for college, went to University of Colorado, Boulder, majored in molecular and cellular biology, did my medical school at University of Colorado, did my psychiatry residency at University of Colorado, and then I've been employed by University of Colorado since 2009, first at Denver Health, the county hospital. I worked in the psychiatric emergency room, and then since 2013 here on the Anschutz campus.
Let's talk a little bit about your experiences as an associate professor of psychiatry and neurosurgery at the University of Colorado. What is it that you do as an associate professor since 2013?
Well, originally in 2013, I was hired to be the medical director of student and resident mental health. So we treat the health professional students on this campus, medical students, dental students, physical therapy students, et cetera. And I grew and expanded the program. I turned that role over to Dr. Julie Wolf about a year and a half ago. And now I have multiple roles. So about 50% of my time is clinical. So I see patients. I still see student, resident, faculty patients, have a lot of physician patients, researcher patients. I specialize in the treatment of obsessive compulsive disorder, and especially severe and treatment-resistant obsessive compulsive disorder. So not only do I see patients for medication management and therapy, I do deep brain stimulation, which is a neurosurgical procedure. So I obviously don't do the surgery part. I'm not a surgeon, but I do the programming part. And then I have a lot of administrative roles. So I'm the vice chair for clinical affairs in the Department of Psychiatry, which means I oversee all the clinical services and strategy for the department. I am chief of service for the CU Medicine outpatient practices. So basically all of the outpatient practices in the adult psychiatry division. And then I'm medical director of a couple programs. So the OCD program and then interventional psychiatry. And interventional psychiatry encompasses our deep brain stimulation program. We have a transcranial magnetic stimulation program. We have an S-ketamine or a ketamine service, and we do electroconvulsive therapy at the hospital. So that, I think, sums up my roles, but I have a very diverse job here at CU.
Okay. It's my understanding that you are also a liver donor. Can you please explain circumstances behind that? Where did it take place and when?
Yeah, so I actually learned about living liver donation when I was a medical student back in 2000, I think, and I thought that was the coolest thing ever. And I thought, well, I want to do that. That's pretty amazing. And I actually reached out to the medical director of liver transplant, and he took me seriously and met with me, even though non-directed liver donation wasn't really a thing back then. But I couldn't. It wasn't very realistic for me to do that as a medical student, and kind of put it in the back of my mind. And 2021 came across an article on the UC Health website, so the hospital here associated with the university, and it was from someone who's a double donor. So she had donated both a kidney and part of her liver, both in a non-directed manner, so to people she didn't know. And as part of that article, there was a link to fill out the form to be evaluated. And I thought, well, I really just filled it out without even thinking much. I thought they're going to not want to touch me with a 10-foot pole because I do have some psychiatric diagnoses and I take psychiatric medications. But so I followed it up with an email and I said, hey, you're going to see my medication list and you're going to think no. But no, they were very reasonable. They reached out. Went through the evaluation process. They obviously did consider my mental health diagnoses, but they considered them very reasonably. They wanted to make sure I was stable, that I had adequate support, that I was aware of the potential implications of donation and the effect it might have on me. And then ultimately, I donated the right lobe of my liver to someone I didn't know at the time in January of 2022.
Okay. Let's talk about your research and your experience with lithium and kidney transplant and your paper, Lithium and the Living Kidney Donor, Science or Stigma. First of all, why did you write this paper? What led you to write the paper?
Well, after I donated part of my liver, that was a pretty profound experience. And I know I knew that at UC Health, they had people who donated both kidney and part of their liver. And I decided I wanted to also pursue kidney donation. Now I knew I take lithium, and I knew that because I take lithium, that would likely be a barrier because there's this perception that lithium is highly nephrotoxic or very bad on the kidneys. And so when I first approached our transplant center, they did automatically say no, the lithium is an exclusion factor. So I sat on that for a few months and I thought, I'm a psychiatrist. I understand the risks. I know that the risks are actually quite low. Is this a battle I really want to fight? And at first I wasn't sure because it's a little embarrassing to try to convince someone to let you do something that they think is foolish or risky. And two, it would mean having to be very kind of open about taking lithium and my thoughts about that and kind of sharing that. And so I very gradually, I approached some other centers. I was curious what they would say. And almost all of them said the same thing. They said, no, if you want to stop the lithium, we'll consider you. But I'm thinking, well, that would be a dumb idea. I'm a psychiatrist. You don't stop something that's working, right? Like that would make me question someone's suitability as a donor. So that wasn't an option. And eventually I did find one, eventually I did find one center that was willing to consider me, but they had some concerns about my anatomy. Ultimately, I decided, there is no literature about this, about lithium and living kidney donors. I think I should write. And, I've published before, usually related to OCD or student mental health, but I approached some of the faculty at CU Anschutz and asked if they'd be willing to write it with me, and they were. And so we wrote this. It was basically an opinion piece based on a review of the literature. And in the context of having written this and gotten it published, UC Health was willing to reconsider me as a potential living kidney donor. I went through the process. Interestingly, my GFR, so my kidney function was excellent. It was 105, and in order to be a living donor, it needs to be, usually 80 or higher. And so even though I've been on lithium for more than 10 years, still have an excellent GFR. What ended up being the problem was my anatomy after donation of my liver would make it too risky to donate a kidney, because my part of my intestines are now stuck to my right kidney, so they'd have to dissect that off. And on my left side, my liver has grown back and basically wrapped around my spleen and my left kidney, so it'd be very hard to safely get in there and get the kidney out. But ultimately, I was very glad I wrote it, because it felt like my ultimate reason for being denied made sense, whereas initially my reason for being denied I didn't agree with. And it looks like Uncle Jim is coming back. Maybe.
Dr. Davis, I'm back.
Okay. I think I basically just explained that my ultimate reason for being denied ended up making sense to me, whereas the initial reason didn't. And I'm glad I challenged that and ended up in a place that was easier to accept.
Okay. From your paper, it's my understanding that about 10,000 people are removed from the kidney transplant waiting list each year. Either they're too ill to transplant or they're removed because they die. Can you please explain what's going on with that?
Yeah, so even though we have dialysis as a means to prolong someone's life, dialysis is far from a perfect treatment, and so people are still facing, consequences of living with chronic kidney disease. And so even someone on dialysis could end up with, let's say, severe heart disease, or just lost them again. But they could end up with severe heart disease or other illness where basically they would become too ill to tolerate or survive a surgery. Hopefully Uncle Jim will come back.
Sorry, Doc, just keep talking.
No worries. Yeah, I basically said that people are removed if they become too ill to that they wouldn't necessarily survive surgery. And that could sometimes be due to the kidney disease itself, but it could be due to another illness, for example, a cancer or something else that would make it make them not eligible for transplant.
And yet at the same time, the number of patients needing a kidney transplant continues to steadily rise. Is that correct?
That is correct, unfortunately, yes.
Please tell us why live donor kidney transplant, LDKT as you put it, provides superior outcomes and survival benefits relative to the deceased donor transplant.
Sure. Well, there's several reasons. One is that the longer someone's on dialysis, the higher risk of transplant failure once they are transplanted. So if you have living donors, you can get people off dialysis more quickly. Kidney from a living donor lasts longer on average than a kidney from a deceased donor. So I think they say 15 to 20 years is the average for a living donor versus more like 10 to 15 for a deceased donor. The kidney from a live donor functions more quickly, and people can get off dialysis more quickly. Just in general, from an economic standpoint, being on dialysis is very expensive to the system. So if someone can get a kidney transplant, it's less expensive to the healthcare system. And then you can't forget about quality of life, right? Being on dialysis is takes a tremendous amount of time. People feel terrible, and it's hard to live life when you are dependent on dialysis. So if you can get someone off of dialysis sooner with a living donor, then that's pretty good.
Oddly enough, the number of living donor kidney transplants has decreased over the past few years. Can you talk to us about why this is occurring?
Yeah, I don't know that we know exactly. It's interesting. So since 1988, the number of transplants increased, and so did the number of living donors up until about, well, the early 2000s. And then for reasons we don't fully understand is number of kidney transplants continued to increase, but the number of living donors basically leveled out. So the percentage of donation or percentage of transplants from living donors is much lower. One of the thoughts is perhaps it's due to increasing health problems in the US population. So we do know that the rate of obesity continues to rise in the US, and obesity is a factor that limits someone's ability to be a living donor. There have been some studies that show that the greatest reduction in living donors is in men in the lower income range. And so being a living donor can actually create quite a bit of financial hardship for some people if you don't have, the ability to take extended leave and have your wages covered and have someone to care for you. It's almost a luxury to be able to do that. And for example, when I donated part of my liver, I have excellent benefits. I could take enough sick leave. I paid sick leave, and I had a friend who could take care of me. And so, a financial hardship seems to be a limiting factor. What I haven't seen is if there's research on is it that the same amount of people are coming forward, but the need keeps going up, or are more people coming forward and also more people getting denied? I don't know that we know that.
Okay. Why is it so important that transplant centers employ a evaluation process that safely maximize living donor kidney donations?
Well, I think because the need
what methods do you feel should be utilized?
I'll say that last part again.
Why is it important that transplant centers employ evaluation processes that safely maximize living donor kidney transplants? What methods do you feel should be utilized?
Sure. So I think it's important because the need is so high, right? There's 90,000 to 100,000 people on the wait list, and each year only about 25% of those actually get a transplant. And so if you maximize the number of living donors, then you could increase the number of people actually able to receive a transplant. And if transplant centers make decisions based on erroneous information or bias or stigma, that's decreasing the pool of people who could actually donate. The other thing worth considering is that donors should be given autonomy to make their own choice about risk within reason. I mean, as physicians, we are taught, and we feel it's our responsibility to guide people towards making wise decisions, but we also let people make decisions that maybe don't necessarily make the most sense. And one of those examples is cosmetic surgery, right? People can have cosmetic surgery. It has no medical benefit to them. It's putting themselves at risk. They're undergoing general anesthesia, yet we let them do it. And so why are we more paternalistic towards people wanting to help someone else? Why do we feel it's more necessary to prevent someone from helping someone else versus, for example, letting them have cosmetic surgery? I think that's something we really need to think about as medical professionals and reevaluate that within reason. Again, we don't want to encourage or allow someone to do something grossly destructive, but we do need to let people have some degree of autonomy.
Okay. Your paper states that decisions about donor candidacy should be based on the best available data rather than on processes prone to bias. Here we examine the common practice of declining potential donors based solely on treatment with lithium. We conclude that the risk of end-stage renal disease related to lithium treatment is comparable to other accepted risks in living donor kidney transplant. Please explain why lithium patients are excluded from the kidney transplant process without good cause.
Yeah, I think there's several reasons. So lithium has this reputation of being a highly nephrotoxic drug. At least that's the perception, or in other words, that it's very bad on the kidneys. And I think some of this comes from older data and older experience. So years ago, people used to use lithium at much higher doses. We do think, although the data actually is contradictory, that perhaps those higher doses led to an increased risk of kidney damage, because lithium does have some risk of kidney damage. But the more recent literature is actually not necessarily in agreement with each other. So some literature actually suggests that there is no increased risk of end-stage renal disease with chronic lithium use, and other literature suggests that there is a risk, but it's low. I think several reasons why lithium is seen to be an exclusionary factor is that, I think people are often wary of letting someone with a mental health diagnosis or psychiatric diagnosis be a living donor, because there's a question about, do they have the mental ability to make the decision about what's in their best interest. We know in medicine in general, people with mental health diagnoses face stigma and bias in seeking any sort of medical care. And so I think wanting to be a living donor is just another example. And then I think sometimes people with a diagnosis of bipolar disorder, now this is based on my colleague's experience, not my own, but my colleague, who is a transplant psychologist, says that, people even with a diagnosis of bipolar disorder who aren't taking lithium may be excluded just because in the future they might need lithium. So those are several reasons why I think people are excluded. But I think all of those reasons, or none of those reasons, are reasons to just exclude someone without consideration, for kind of a carte blanche exclusion. So what our paper did, or what we did, is we looked at. So I just kind of started talking about what our paper looked at. Is that where you wanted to go next, or?
Talk to us a little bit about why lithium is taken. What kind of things does it treat?
Yeah, so lithium lithium is really considered the gold standard for bipolar disorder. So it treats both the depressive phase. So bipolar disorder is a disorder where people experience periods of depression, and then they also experience periods of mania. And during periods of mania, people may be, they have grandiose thoughts, so they believe they're more important or special than they are. They may spend too much money. They may behave impulsively. Sometimes people may have psychosis during mania. They may have risky behaviors. That's bipolar type 1. There's bipolar type 2, where people don't become fully manic, but they become hypomanic. So they basically function super well, but it doesn't cause problems in their life. But it's very distinct from, say, their normal baseline or their depression. And then lithium is also used in what we call unipolar depression, so kind of regular depression, where someone doesn't have hypomania or mania. And it's actually one of the best treatments for severe and treatment-resistant depression.
Okay. So let me ask a kind of a sum-up question. We have a need for transplants that has steadily increased since 1980, and the number of patients needing a transplant has increased. At the same time, the number of living kidney transplants, a superior method to deceased donor transplants, has decreased at the same time. Is it true that in 2005, living donor kidney transplants represented about 40% of all transplants, but as of 2022, they are now representing only 23% of all kidney transplants? Is that a true statement?
Yes, that's accurate. And that's part partly, or that's due to the number of transplants increasing while the number of living donors just staying steady or even slightly decreasing.
So for end-stage renal disease kidney patients, there are less opportunities currently for a living donor kidney.
Correct.
Okay, I'm sorry about this, Doc.
No worries.
Just keep that continues. Is this decline expected to continue?
I don't think we know, but ideally we would determine solutions to actually increase the availability of living donors.
All right. Your paper explains that there are attributable and acceptable risks in potential living donors that are not being considered, and that lithium is the gold standard for treatment of bipolar depression, for example. Why do we need this group of people that are taking lithium as part of the potential living donor process?
Well, I suspect it's a small pool, and the point of this paper is broader than just lithium, people taking lithium, right? The point is, let's look at the evidence, the real evidence, and not make assumptions based on bias or erroneous historical beliefs. And so people who take lithium are probably a small sample, but even a small sample, you take several small samples and those add up, right? And so I think this is just one area where we can challenge beliefs and start to increase the living donor pool.
Okay. Let me put it this way. Should every patient, including lithium patients that want to donate a kidney, should they be evaluated each individually on their own to see whether or not they are within the science of acceptable risk?
Yes, yes. So there's a really interesting paper. I'm not remembering the authors off the top of my head, but they took kind of one of the standard ways of estimating risk of end-stage renal disease, and that was a three-factor equation. Basically, it looked at age, sex, and GFR. Then they took people on lithium, and they had this very complex 44-factor model that they looked at. And what they found is that this 44-factor model was no better at predicting end-stage renal disease than the standard three-factor model. So, and the 44-factor model took all these things that were specific to lithium. And what that suggests is that even when you consider all these things specific to lithium, the three-factor model is just as good. So you can take people on lithium and use that three-factor model, or, look at their GFR, consider their age, consider their sex, and make a decision based on that and all the other things that you would normally consider in evaluating a potential donor. But excluding someone simply because they take lithium makes no sense. Transplant centers are willing to accept other risks, such as, a BMI above 30, or even sometimes above 35. People who are Black have a higher rate of end-stage renal disease than people who are white. People who are male have a higher rate of end-stage renal disease than people who are white. Yet, no one would argue we shouldn't take male donors and we shouldn't take people who are African American. That, people wouldn't argue that. People take people who have controlled hypertension. Some centers will even take people with type 2 diabetes that's well managed. One of the biggest risks, if not the biggest risk, of end-stage renal disease is being related to someone with end-stage renal disease. Yet most living donors are related, right? That's the biggest pool. of living donors is people who are related and want to help their family members. Yes, that is also one of the biggest risks and predictors of end-stage renal disease. So really, our paper just wanted to highlight that we have all these other risks that I'm saying medical profession in general, have determined to be reasonable, yet lithium, which, my paper goes over what these risks are from a number of papers, the risks associated with lithium are similar to the risks of these other generally accepted risks.
Okay. How do you respond to the issue that the potential side effects of lithium could be kidney problems?
They could be.
It's one of the known side effects of the medication.
Right. So that's where it's important to look at what exactly is the risk. So, and I think that's what I was just explaining is that the risk in the literature is actually very similar to other risks, and it's actually quite low. At the highest end, let me just look at my paper. I don't remember off the top of my head, but the highest risk of some of the papers of end-stage renal disease were, 0.2%, and in some of the papers, like, it wasn't even a significant finding, or 0.1%, or some of the studies looked at decline in GFR that they could attribute to lithium, and actually the decline in GFR was similar to what's observed in a normal population. And so, I'm not arguing that lithium has zero risk of kidney damage, because we know it has some. I'm just, the point of the paper is that the risks are similar to other acceptable risks.
Under the Organ Procurement and Transportation Network Policy, Section 14.1A, it mandates that all living donor candidates receive a psychological evaluation. That would include a mental health study of lithium patients too, wouldn't it?
Correct.
Okay. Your study makes certain recommendations, including medical evaluations and psychological evaluations. Can you please discuss with us the recommendations made in your study?
Yeah, so what we suggest is that just as one would evaluate someone's medical problems and whether it's safe to proceed, you should take a similar approach with someone's psychiatric problems. So, someone with controlled hypertension may be an acceptable candidate, but someone with evidence of, end-stage organ disease, like severe cardiovascular disease, would not be an acceptable candidate. So you take the analogous situation with someone on lithium. We're not saying someone on lithium or everyone on lithium should be considered. If someone is actively suicidal, or their lithium levels are frequently toxic and they're ending up in the hospital because of that, or they have a history of being repeatedly suicidal, if medications change, or they don't have psychosocial support, or they don't have a realistic understanding or plan for what happens if their mental health worsens if they donate a kidney, those would not be suitable candidates. But let's say you have someone like me who takes lithium for, I have bipolar 2, and I take it mainly for the depression part of bipolar disorder. I function very well. I function as a physician. My levels are very low because I only take 300 milligrams. I've never had an episode of toxicity. I have a good support system. I have a therapist. I have a psychiatrist, and I would be able to put a plan in place for what would happen if I did, struggle after kidney donation, similar to when I was considered for liver donation. So that's just an example.
Okay. What conclusions did the study come to?
Mainly that, in a specific sense, lithium should not be an automatic exclusion, that people should do a thorough psychosocial evaluation just as they do a thorough medical evaluation, that you can base decisions about candidacy related to lithium and kidney concerns based on standard evaluation processes of kidney function. And that not only should this be applied to people taking lithium, this is a bigger message to the medical community to really look at the data and consider the data and not make decisions based on old literature biases or stigma.
Okay. Do you have any work in the future on the issue of kidney transplant donors or kidney transplant in general?
I don't specifically at this time. I'd be open to feedback from people about where they think the needs are and what next steps would be. I do think it would be interesting at some point to survey transplant centers across the U.S. and just ask them about their practices with kidney donors on lithium, and whether an article such as ours would lead them to reconsider. I think that would be interesting to do. But no, I don't have anything specific planned at this point.
Okay. Do you have any final statements that you wish to make to our audience today?
I think what I would say is that I feel that as a physician, I was privileged in my ability to pursue this and come to an understanding and actually have a discussion with the transplant team about what I thought made sense scientifically. And I recognize that partly that happened because I'm a physician. And I think that many people are in less favorable positions where they might be denied and they might not understand why, and they don't have the opportunity to have that discussion. And I would just encourage people, if you're interested in being a living donor and if you're denied, it's okay to ask questions and it's okay to try to understand why. Perhaps you're denied for a reason that's something you could do something about. If you're declined because you have a elevated BMI, maybe you could work on an exercise and diet program or get involved with a health coaching. And so I think it's hard to ask questions to medical providers, but I really want to encourage people to ask questions because it's your right as a patient or as someone who wants to be a living donor to understand the processes and to understand why you're denied if you're denied, and to question that, question that politely and considerately, but you don't have to just accept answers without understanding reasons.
Okay. Doctor, I thank you so much for coming on with us today and talking to us about this very important issue. And in particular, the issue about lithium and potential kidney donors being excluded almost automatically without individual evaluation. That's just wrong. I appreciate you being patient with me and my broadcast medium. For some reason or other today, it decided to take a couple of breaks in the middle of the broadcast. I apologize to you for that, but I do think we presented a very cohesive program, and you did a wonderful, wonderful job of explaining your position to us. And the fact that they allowed you to make a liver transplant, a portion of your and it seemed to have issues with and kidney donor transplant, not doing individual evaluations. That just doesn't make any sense. So I'm really happy that you wrote that paper. And I want to tell our audience, in my original broadcast announcement, pinned to the top of my Facebook page, is all kinds of other information about Dr. Davis and her position, and a link to her paper, a link to her broadcast with our good friend Kent Dressler at Kidney Solutions. And if you want to drill down on this issue a little bit, just check out those links. And again, Doctor, wonderful broadcast, just a terrific learning experience. I learned a lot, even though I was only here half the time. So,
Well,
I
thank you.
appreciate it very much. I have some stuff I have to button up with my audience, and I'm going to let you go. I know you're a busy person, and I promised you we get this clicked in an hour. 41 minutes, not too bad.
Sounds good. Well, I really appreciate you having me. I enjoy talking about this, and I appreciate the opportunity. So thank you very much.
Oh, it's wonderful. Wonderful. Thank you so very much. You have a good afternoon, and I will be in touch with you very soon.
Sounds good. Thank you. Bye.
Bye-bye now. All right, folks. Sorry for the interruptions. That's our broadcast. I'll be sharing the replay very soon. Thank you for tuning in.